yet, so I'm kind of bummed, but
Yeah.
There's still time.
yeah, exactly. That's what I say every April.
So Terry, would you mind, I think everyone on this call knows who you are, but do you want to do a little background of where you're currently at, what research you're doing, and
Yeah, excellent. Yeah, and then so my name is Terry Grindstaff. I'm an associate professor at Creighton University, which is in Omaha, Nebraska, hence the connection with Nate. And I've been at Creighton for about 10 years now. And prior to being at Creighton, I was at the University of Virginia, where I did my PhD. And then I also kind of split time working in the athletic training room, primarily with women's rowing, but also men's and women's golf, as well as wrestling. So that's kind of my past 10-ish, 15-year background. A lot of my research looks at the neuromuscular consequences of lower extremity injury. And really, like, why I got into it is sort of thinking of this reflexive inhibition. So somebody hurts their knee and their quad doesn't work. And it's like, well, why does that occur? And then if we can kind of understand, well, why does it occur? Then what can we do about it? And so that sort of leads into a lot of different lower extremity pathologies. The knee's pretty easy to study in that regard. And, you know, because you hurt your knee and your quad doesn't work. And so it's a fairly clean joint from that perspective. The quad's the only knee extensor. And so, you know, there really aren't a lot of other muscles or joints in the body that just have one muscle that essentially carries the load. And so that's kind of my research interest is figuring out, well, why does that inhibition occur, and then what can we do about it? So it can really span from patellofemoral pain to ACL reconstruction or knee OA. You know, there's basically, if you hurt your knee, I can pretty much tell you with certainty your quad's not going to work as well. So that's you know, me in a nutshell, if you will. So yeah, and then I did a book chapter in the NSCA textbook as well. Yeah, so a rehab and reconditioning chapter with one of my good friends, David Potach. So yeah,
got it. Sweet. Well,
so yeah, could we do an introduction with you guys? I mean, I'm new to this group, so thanks for having me.
Yeah, sure. So this is hilarious. So I started as a first year. Our school doesn't have a journal club, so I started it up, and it was supposed to be just like in person, get students in my cohort, try to like develop some type of weekly journal club, and that kind of lasted for a semester, and then COVID hit. I was like, well, I want to continue this, so I'm gonna do it through Zoom, and I then reached out to other students and then other kind of new grads, and pretty much now it's like very few people from my cohort and a lot of random like other clinicians and like new grads and students,
awesome.
Which is great, but it's like, I call it UT Health San Antonio Journal Club, but it's kind of a hodgepodge of people. So I'm a second year student. We just started our fall semester, and yeah, Shelby, do you want to go?
Awesome.
Sure. Hi, Terry. I'm Shelby. I'm a physical therapist out of Fort Worth, Texas. I've been out for about 2.5 years and work in a sports setting, so see a lot of ACL. So I'm looking forward to this talk.
Excellent.
All right, I'm just going to pick people in my row. Travis, you want to go?
Hi, I'm Travis. I just finished my PhD in rehabilitation sciences at Drexel University, and I'm particularly interested in ACL rehab, and Chris asked me to come on in particular today just so Terry wouldn't be the only PhD on the call, so here I am.
Nice to meet you.
You too.
All right, Nate. Terry already knows you, but you want to do a little intro?
Yeah, I'm Nate. I'm my third year at Creighton University in PT school. I'm still in Omaha right now doing a clinical rotation, but at Creighton we do this journal club that Terry leads, and we call ourselves Grindstaff Goons. So, just kidding. I just made that up.
That was great.
Thank you.
Paul, you want to go?
I'm Paul. Been practicing for 25 years. I practice in Arlington, Texas, and I'm just a nerd, so this is fun to me. So
that's awesome. Good meeting you.
All right, Kevin.
Hey Terry, thanks for coming today. I am one of the UT Health OGs, so just continuing on and really enjoy honestly the Zoom, because it's nice to have some different perspectives coming in. So just a second year at UT Health San Antonio.
Excellent.
All right, Alec.
I am unfortunately not one of the OGs, but I did go to UT Health. I just graduated a couple years before Chris and Kevin got there. I graduated in 2019, so I've been practicing for a little over a year now. I work in outpatient in the Dallas area.
Good to meet you.
Okay, all the people who don't have their cameras on, for some reason, it's not showing me who's on here. So if anyone wants to unmute who doesn't have their camera on and introduce themselves, that's cool with me. If not,
I'll go ahead and start. Oh, go ahead.
Oh.
Go ahead.
Okay. I'm Laura, and I'm also a second year at UT Health San Antonio.
Excellent.
I'm Alberto Barrera. You can call me Bert. I'm also a second year at UT Health San Antonio.
Hey, I'm Joey. I'm cooking right now. I'm a new grad from North Texas. Kind of doing my own thing. I'm looking more into like home health recently.
Awesome.
I think that might be everyone. Oh wait, no, we got Annie and Devarshi. Either of y'all want to?
Yeah, sorry. Hi, I'm Annie. A little bit different background. I just graduated from undergrad. I'm a coach now in California. That's how I kind of met Chris. We both had the same mentor. So I'm deciding when I kind of want to go back to PT school, but I think this is a good way for me to kind of keep learning. So excited to be here.
Awesome.
I am from India, and I completely finished graduation like 5 years back. So this is just to get in touch with more recent things and not just stay where you are and keep learning.
Excellent.
I think that's everyone, which is, we got a legit diverse group going on. So
yeah, this is phenomenal.
Yeah, all over the place. But it's cool that you actually have the journal club at your university. And is it through the whole like DPT program, or how do you run that?
So our journal club's kind of been an evolution, if you will. And so really we've probably run, some sort of journal club or reading group, and it's mainly with the students who have interest in research is traditionally what it's been. But probably within the past 2 years, we've sort of opened it up. And so at Creighton, we don't have, we don't have like a PhD. And so, and our DPT students are not required to do research. So it's all through independent study essentially. And so they take an independent study course, and with that, then we sort of have journal club. And what we started to see was that, that really things started to, branch out, and other people had interest in the things we were doing, but they didn't necessarily want the research component. And so the past 2 years, we've sort of opened it up to others. Hey, if you want to do the journal club, you can, and you don't have to do the research component. If you do the research component, you need to be at journal club. And then now, starting this fall, we will offer a 1-credit elective, which is just, it'll be called like special topics in rehabilitation science. It'll be journal club. The students will get academic credit for it. And then we'll still offer the kind of the independent study research route as well. So our journal club has traditionally been mostly Creighton DPT students. some interested individuals from the community like David Potach, but he's kind of plugged in on the research side of things. And then last year I was away. I did a fellowship at the Naval Health Research Center in San Diego, and we started doing Journal Club on Zoom. And so then like, you know, and others would kind of start to get interested, and then COVID hit. And very similar, I think, to your group, like we had kind of done that like over the summer. And then we just kind of started to expand it. And some of it just happened by accident. But one of our DPT students, her sister is a PhD student at the University of Delaware, and happened to be one of the co-authors on one of the articles we were reviewing. So Amy's sister pops on for Journal Club, and we're like, man, this is a great idea. Like, why don't we invite other authors or just other people to come talk about like the papers that they wrote or whatever, and then we could ask questions. So it wasn't to pick on them, but it was to kind of get their insights. And so that's kind of what we've done. We've taken a little bit of a pause like the month of August, because really all of our students are out on clinicals right now. And so we'll kind of look to resume those within the next couple of weeks. So that's kind of how we've run our Journal Club. But I think silver lining, like this, these options on Zoom and kind of options for remote learning have been outstanding. And just to get perspectives from all over the country or all over the world, like, it's like, holy cow, this is great. Like, why weren't we doing this before?
Yeah, I mean, we are back on campus, UT Health, but it makes more sense to keep it through Zoom because you get way more interesting people involved. So that's great. So you are the first professor we've had on Journal Club. It's been no pressure. It's been a few, well, Meredith Chaput was on. And so she's, I guess, like the highest like PhD currently that led. And then we've had a lot of new grads and clinicians, and then some students lead. So it's great that we have finally like a researcher professor joining the party. So you linked 3 different papers, and you did the documentation for strength training as kind of like a background. And then the other 2, how do you want to start and preface this?
So yeah, the documentation for kind of the strength training for research purposes, again, that's just completely all background. So it kind of sets the hopefully sets the stage. And I guess kind of why I started to go down this route. And again, looking at people that have, say, knee injuries, but really it could be any injury. You could use the shoulder if we wanted, except there's a lot more muscles that attach to the shoulder. But sort of looking at, post-injury outcomes or post-operative outcomes. And it's like, wow, we're probably not doing as great as we could. That's not a knock on rehabilitation, but it's like, I think we can do better if, you look at people with ACL reconstruction and that, 20 to 30% have re-injuries, or that, nearly 50% develop knee OA like within 10 years. And so you kind of start to look at that and you're like, can we do better? And then now some things are coming out that, people, even when they're going back to activity, post-op ACL reconstruction, that 30 to 70% of them have deficits in strength or, jumping and landing biomechanics or sport performance, or, that some of them aren't even getting back to play. And it's like, well, what are we missing here? Now I realize and appreciate there are a lot of different things that contribute to that. But just from a very basic standpoint, I'm like, okay, if we just pick one, and in my opinion, like, I think that like just quad strength is kind of a rate limiting factor. That doesn't mean that other things don't play into that, but I think I really look at, you have to have a base level of requisite strength to be able to do things. And if you don't have that, then you can't be powerful. You can't jump high. You can't sprint fast because you don't have the basics. Now, what we see though is athletes are really incredibly, have a great capacity to adapt and compensate. And so somebody can maintain their performance without having the required strength of their quad. And so I'm like, well, we should probably be pretty good at strengthening muscles in theory. But I think sometimes from like let's just say from a physical therapy perspective, there's sort of, I don't know, word on the street is we kind of typically underdose exercise. And I think there's a lot of reasons for that. And I realize there's real world reasons like insurance and we don't have enough visits and things like that. Unfortunately, I live in like this ivory tower and it's like, well, I don't know what to tell you from a research perspective. And so I get it. There's a disconnect there. I also think most PT programs could probably do better in the area of therapeutic exercise, and where I would say probably most undergraduates coming out of a strong exercise science program probably have a much better appreciation for exercise prescription and strength and conditioning principles that then can be applied to an injury population. But I think we missed the boat from a physical therapy perspective. So sort of looking at that as, okay, well, here's kind of the foundation. Yeah, and Shelby didn't even offer a TheraX class. And it's like, you know, we hear, well, we're exercise experts. And I'm like, I don't see it, but that's, I've said that for 20 plus years now. And it's like, well, you can learn that stuff on clinicals. And I'm like, well, if your CI never learned it, it's going to make it pretty hard. And so I think that's a starting point. And so that was really the rationale for, okay, well, let's look at these other two articles that that sort of discuss kind of approaching late stage ACL rehabilitation, kind of from more of a strength and conditioning perspective. And but I think it was important to look at, well, in this Augustin article from 2013, I think sort of helped set the stage for, hey, here are the things that could maybe be done better. And then we can sort of, then in theory, we can sort of build from that. But so the two articles, and usually like I don't know how you all run Journal Club or whatever, but usually like I try to get like, well, one, I probably talked way more than I need to now. And then the rest of it will be just kind of facilitating that discussion. And so, quick 30-second summary, both articles. What are your takeaways? Go. Anybody talk?
All right, I'll go. I'll do the progressive strength training, restoring quadriceps and hamstring. Quick little summary here. It was a smaller group, but I mean, it's not like we're looking at systematic review. So it's just a smaller group, and they measured now I'm blanking on the times. They measured at 3 different periods of time the quad index for strength. And I thought it was actually kind of weird. Their control group here was an uninjured population of other athletes, which just kind of seemed odd to then have that be the absolute control versus ACL reconstruction. So, and then they went through it. They also looked at between bone patellar grafts as well as hamstring grafts. And there was a difference in quad strength at the 7 and 10 month marks for the hamstring being stronger than the bone patellar, and it just suggests that we aren't loading enough and getting the strength back for a return to sport.
Good article, bad article, indifferent?
I thought it was good.
Okay.
I thought it was good. I thought it brought in like a lot of different parts of the research around ACL rehab. The one thing I really wasn't a fan of was that control group. It didn't really seem to bring that much to the table. And there's definitely room for improvement there. Like have a control group of, ACL reconstruction surgeries, and then have them follow sort of a different protocol when it comes to the, resistance.
Okay. Any other quick thoughts?
I think the main aim of the study was to compare what your strength would be after the surgery and without any injury or surgery. So their thought process was different, which is why they took the control group of normal individuals who had not had any injury. So they just wanted to compare what the quad strength would be if they had not had any injury or had any surgery. So it was like more of a at par to figure out whether after your rehab you were able to reach the strength that you would have had if you had not injured yourself. So it was more of a comparative. So I think this was good. Like if that would be another study altogether, but I think the main aim of their study was to figure out the quad strength.
Okay. Other quick thoughts? How about other thoughts on the Amy Arundel article, the ACL sports trial?
I thought it was good. I was a little confused on how they separated the SAP and the PERT, the differentiation there, and then where in the rehab process these patients were coming from. I think they all had to have like 80% quad symmetry back and some other markers. So I'm assuming they were all pretty far out, but I don't remember it saying specifically kind of what cohort they were a part of. I mean, it was interesting that they all kind of did better on these hop tests, but again, is it that impressive that they got better because they were just doing a bunch of different plyos and jumps? You would assume they would improve. I didn't know what like a big takeaway there was. It was interesting that the males increased, I think, quad index at the end, and then the females didn't have any change. But I don't think that was really their main goal, because this was more looking at the hop tests and the other kind of outcomes, less from like just a quad force production standpoint. So I thought it was good that you like brought more of a jumping plyo hopping paper and a more like pure like quad strength to kind of have those two big markers. So I think they like mesh together nicely.
Yeah.
I did find that paper a little odd though, because they talked a lot about quad strength. And then if you look at their programming, I think they had them do banded squats for 6 sessions. Like, what the hell is that? Right? I mean, yes, they're jumping and doing some other things, but to actually address the quad strength that they talked a lot about, I didn't see much of anything as far as addressing true quad strength. So it seemed almost absent in the programming. And it's like, if we're going to talk about it, should you not be also addressing it? You're measuring thigh index, yet again, we didn't really program for any of those changes. So why measure them?
Yeah, I was same here, Paul. Like I was confused if they were doing stuff outside of these protocols from just a resistance training perspective, because literally the only kind of resistance training they had was as you said, the standing squat, which is extremely
Right. And if they're doing that, then how can you say males made better than females? Because maybe they're just going to the gym more because of bro science or whatever call that they need to meet for that. I mean, it draws. I was a little confused about that. I do like that they looked at the hopping and some of that comparison and whether or not the perturbation training was going to drive any changes there. But if we're talking about quad strength, where was it that you were addressing that in the program?
And also the fact that it was only 10 sessions. I don't know how frequent the sessions were, but then again, like how much change, long-term change are you really creating in just 10 sessions of doing anything from like a structural perspective?
When I was reading that, I thought like they were doing like on-field exercises, and now that I'm like looking through the paper again, I don't think I see it anywhere. Because like I was thinking like maybe they're just doing on-field exercises, and that's why there's no like knee extension or or anything like that. Because like you can do banded squats if you like partner up, and like the Nordics you can do with another partner. I don't know. That's kind of what I was thinking, but I could be wrong. I might have just incepted that thought in my own mind.
Yeah, you're hoping they're controlling other things then, because there's no statement of that. So you know what I mean? I mean, you're hoping that this is just what they're doing on the field, and they've got other programming going on. But
yeah, and so I think that's the having some idea and anchoring it back to kind of the first article as far as kind of the documentation of the strength training. And yeah, you can go back to kind of the original, I think it's Kathleen White, that was kind of the lead author on the ACL sport program, kind of, as they were designing that clinical trial. But again, it's, I think the term progressive strength training is often used. And then it's kind of like, well, what do you mean by that? Like, how is it progressive? And it's like, well, when their quad index was, above, a certain threshold, then we just sent them and go continue to do stuff in the gym. And it's like, well, we should probably give people better prescription and better oversight versus go do the strengthening on your own, especially if they're not hitting relevant strength benchmarks. So let's start then kind of with this, the functional and patient-reported outcomes improve over the course of rehabilitation, kind of the secondary analysis. So let's cover this Amy Arundel article to start, and then usually, kind of journal club wise, we kind of walk through the introduction, and then dive into methods, and then kind of wrap it up with transition through results and then into the discussion. But what were some thoughts or why do this sort of program, based on the introduction? What's the deal here?
I think, at least what I took away from the intro is that a few things. One, their hop testing and landing and quad index are huge markers of return to sport and the rehab process and the training process. And a lot of the studies that have been done are, as they framed it, level 5 evidence or just expert opinion. Mm-hmm. So they're trying to create a higher standard of looking at these. And so that was kind of setting the tone of why they want to measure in maybe a higher level evidence perspective with the hopping and the jumps.
Do you think, and they sort of, and there are other studies have described this ACL, sports trial, and it's 10 sessions, twice a week. And so it's, done over like a 5-week period. Do you think there's any advantage or disadvantage to something like that?
I think Chris kind of touched on it earlier with if you're actually looking for like physiological change in tissue capacity, 5 weeks is a really short period of time, especially in comparison to the entire ACL rehab process. How much can be done in 5 weeks? Those changes seem to be like they'd be more on the neurological side, and then maybe having some effect on like an athlete or patient's confidence. But from a tissue change, I'm not sure how much is happening in 5 weeks.
I just found I had previously read another study on this trial, also by Arundel from the year before. So maybe that was the previous study was like the primary analysis, and this was the secondary. And this one, the other paper said that they all started with 80% limb symmetry. Or hold on one sec.
That's yeah.
So the inclusion criteria were that they were, damn it, where was it? They had previously gone through rehab and they had already achieved a bunch of benchmarks. So they knew exactly where they were starting, and I guess that was the reason for not emphasizing like quad strength as much, let's say, because they were already 80%. Obviously isn't like a great threshold to begin with, or it's not where you would want to end up, but I guess that wasn't the primary thrust of the intervention.
So why, or what is this ACL sport? Like, what is it? Who's it geared towards then? Or why is it there? Or is there value in that sort of program? So who's it geared for?
Well, I mean, with their same statements, they're looking at injury prevention, right? It's for late stage people that are already late stage. Can we do injury prevention? And a strength of this is sometimes you get done with your traditional course in rehab, right? We're able to do a retest. And if they're falling behind or lagging behind, or we're able to intervene again, it's going to be a short course because insurance isn't going to pay for a lot, right? But we can do a short course where we can get them started on this next phase, right? And this may help guide some of that phase, that late phase of rehab. And then they're going to be bouncing back out, hopefully with better direction than we gave them for their strength training, for some of this other stuff. I would have liked to see a long-term longitudinal aspect of, did any of that really make a difference in injury though, right? If we're, again, talking about it, is there any way to look at, did these 5 weeks and potentially training afterwards make a difference in the injury rate of these individuals?
So yeah, this is the idea is it is a late, in theory, it's more of a late stage program. You've already met some of these other basic benchmarks, the 80% threshold. You don't have knee swelling. So, these are the people that now you are ready to start, in theory, kind of what we would just broadly call kind of a late stage rehab program. And so, that they've met those basic benchmarks. And Paul, to your point, it's 5 weeks in duration. So is this something that could, in theory, translate well to a clinical environment? And so I think that's a potential advantage. But then we also realize, okay, well, if we really want to make some sort of change, then maybe we need more. But then it's like, well, they ran out of visits. So it's like, how do you balance those out? So I do appreciate that they, in theory, kept it real world in that regard.
I also like that there seems to be a lot of papers that will say like they performed a protocol, but they don't go into specifics. And this very obviously shows you the sessions 1 through 10. So it actually gives you a framework of how you could do this, as you said, like in a clinical setting.
Mm-hmm.
Yeah, and I don't know how many other clinics offer this. I know ours, once you run out of insurance or if your insurance doesn't cover you, we do offer like a back to sport program. So it's like 10 sessions for $200. And it's just basically supervised exercise at that point. There's no like hands-on anything. So I think that would be like a good use of 10 sessions in a PT clinic if it operates under that kind of situation.
That's pretty cheap to be able to do it for $20 a session. Is it group based?
No, it's just, I mean, they might be with one other person on like the hour, but it's not like a group. It's either one-on-one or with maybe one other person on the hour.
I almost thought too, like the equipment that they use in the program is also like more real world, because I mean, not if they added like a lot of fancy equipment or a lot of fancy exercises, like the availability of like clinics to do those things might not be there. I know like for the clinic I'm at, like we can do all these things, but they start getting a little crazy. Like we don't have a whole lot of equipment at where I'm at. So that's another thing I thought was good.
So yeah, that is an advantage of that. Maybe it's a less equipment intensive, and so there's some some strength to that. Let's jump into the methods then. Anything did anything in the methods jump out at you? Good, bad, indifferent?
I thought the spread. Sorry, Chris, didn't mean to cut you off. I thought the spread on like participant age is really like, if you've had an ACL, sign up here. Like it seems pretty broad, and so I feel like that's kind of tough to then find or identify a population in which this might be more beneficial than others.
Yeah, exactly. Like, between the ages of 13 and 54, and I'm a lot closer to 54 than I am 13, but I'll tell you, there's a big difference between being 54 and 20. and so really thinking of, and it's not to say that people at 54 can't be athletic, but I'm kind of like, there's probably a difference, or let's maybe be a little bit more focused in that regard. Now, they sort of say, well, they're all athletes and they provide that breakdown, but again, and I'm more closer to the 54 end, but I'm like, there's just like, does that make sense to have that wide of a spread?
Right. And then
why do you think they did that?
Oh, I was just going to add to that, like the intensity of sport. If we're talking, prevention and getting back to sport, the intensity is so varied between that age range. I think is another issue.
Do you think that the wide age range was just to be able to augment their sample size, or there was something that they wanted to be able to make the results generalizable to anybody within, make it more general than specific to, high school, college athlete ages?
Is that good or bad?
Guess it depends who your athlete is that you're trying to apply the results to, right?
It's good and bad, because if it's too generalizable, then you're like, I don't know. But if it's too specific, then it might not. Then if you're working with another population, then you're like, this may or may not apply to you.
I guess if you find results in this really large group, you could be confident that it is going to apply broadly, versus if you do a smaller age range, then like you said, you can't necessarily apply it to other age ranges.
Right.
Well, again, I'll go back to my overriding hypothesis with most research is it's always a group statistic applied to an individual. So you really don't know that individual in front of you, how they're going to respond to what you're applying in the first place, right? So this is the starting point of conversation, jumping off of where we're going to guidepost. And they didn't seem to do any individual testing of those hamstrings with the Nordic curls. Okay, I'm going to progress you at 2 sets of 5 to think, was that an effective dose? All right. How do we know that we get an effective dose for some of these things in the way that they were doing things? So there's a lot of those questions to how are we actually able to apply to an individual? Is 30 degrees of motion enough on a Nordic hamstring for, you know, the 20-year-old that's fit? His index still says the same, but his strength is going to be much different than the 54-year-old lady, right? And so how are we getting that individualization within a program when it's here? I understand that that's the limitations of research, but again, that's the limit in how we apply whatever it is that we have in research, right?
Yeah, and so I mean, you know, I think and I guess that's the fun part about articles or, you know, journal club or science is you could really play both ends of this. You're like, wow, but they have 80 people, and it's very diverse in their age ranges, and you know, and so it should be broad, and we can apply that sort of across the board. But then at the same time, that it is very broad, and so maybe it's not then reflective, or no group is reflective of the one patient in front of you, and the one patient in front of you isn't reflective of the group, and so then you're like, oh, this makes it even tougher, and so it's like, well, then how do I apply this, and what does this mean? And I think being able to sift through that is the sort of the fun aspect. I would suspect that this is very driven on broad appeal, increasing that or having a relevant sample size, but you know, from my end, I think that's, you know, it's also a critique in that, you know, well, let's maybe focus this program a little better, and maybe we just need, and maybe not necessarily a different program, but you know, maybe the people that are 35 to 54 years of age, and I'm just using that as a mildly arbitrary cutoff, maybe their program looks different, or maybe they respond different, but we can't sort that out here. And so, you know, I think making the program focused, I think would make more sense. But again, I appreciate the broad appeal. Anything else jump out in the methods here?
Just another comment on the sample size thing. I think I know that the previous paper, they only published the data on the males. And so that might have been part of it, is that they wanted to have a large enough sample that if they could separately publish the sexes. And there's two reasons that you might want to do that, right? One, because the prevalence and the mechanism of injury is potentially different between the sexes, and also so that you can get 2 publications instead of 1. But like you just said, Terry, like, if you let's say you don't find something in this really diverse cohort, it doesn't mean it doesn't exist in a smaller range. It just means that these effects got washed out, because maybe the thing that would work well for the 13 to 25-year-old is different from what would work best for an older population.
Yeah, I think that's the hard part. Oh, sorry. Go ahead, Shelby.
Oh, no, go for it. You muted yourself. No, the thing that kind of stuck out to me was just that there's 31 different surgeons that did surgeries, because I feel like when you see a lot of ACLs, you do start to see a difference in just how people look after certain surgeons work on them, and just like their own outcomes. So I was more curious on kind of knowing if the outcomes were different between surgeons.
That's another one where it's like good and bad, right? Good, because you can say regardless of the surgeon, we found X, Y, or Z, but then you can't say, well, we know that the surgery was consistent in everybody who was in this study. So that's just kind of added noise, depending on how you look at it.
Something that I thought was interesting in the methods, they said sessions were supervised by a PT, and education was given on correct landing techniques and lower extremity alignment during exercises, particularly avoiding knee valgus collapse. And I know that that's like a hot topic of are you going to train or allow some resilience in that valgus position? And are you consistently going to cue them out of it? And so that might be a discussion for later, but I thought that was interesting that they explicitly put that in the methods.
I think there's also a pretty wide range of like what stage these athletes are in. I mean, I know they tried to qualify it by like saying minimum of 80% quad index and like effusion, no pain, full range of motion. But I think 3 months and like 7, 8, 9 months looks really different depending on like what you've been doing in your rehab program. I mean, that person who's at 7 or 8 months could potentially have hundreds, maybe like thousands more practice at some of those jumping exercises as well.
So what about the training program? Where did the perturbation training program component come from? And then what is it?
All right, I'll go. I feel like perturbation is sort of, I mean, they're using that as more simulation of an actual like sport context. Because if you're just measuring like hop test, or if it's too like clean of a vacuum almost to like measure, and so I think it was sort of a way to introduce more of like a sport component. Yeah, that's
okay. And then why did they want to add the perturbation training? Like, what was the rationale there? And this gets back to the introduction a little bit. Like, where did that come from?
I think what I saw, or what I'm looking at now, is that they're considering it neuromuscular reeducation, which I feel like it's a very vague term, beneficial in helping ACL deficient athletes normalize gait and return to sport.
Okay, so really pulling this from the people that went the non-operative route, sort of, or trying that non-operative route. And so that's where that came from. So probably not a stretch to say, okay, well then let's apply this, in a population that has had surgery. Now tell me about the perturbation training that they did. Like, what did they do?
It looks like balance exercises, double limb, single limb supported, stationary platform, wobble, tilt board, and then functional tasks during those, which I don't know. I think Shelby and I have kind of talked about this before, like what maybe the benefit of, it seems almost more like maybe balance training, or like what we would call balance training in rehab, and like what the importance of that actual training, like what specific effect it might have towards actual sport related activities. And if it does,
you could like make an argument that all of the drop jump, tuck jumps, agility drills, that's all perturbation training, because you're literally being thrown into gravity by your body, which is being perturbed. So, and that's probably a way higher like carryover than just chilling on a rollerboard.
I like the way that Mick Hughes shows the like perturbation jumps with a partner, where you jump in the air and then push your partner. I've seen video of the way that they do it in the ACL sport study, and it's like, and Kevin Wilkes' Instagram, if you're standing on a wobble board and then the physical therapist kind of like perturbs the board, and it's like, yeah, I can see why that might be something that you would want to do, but it's not totally clear what the crossover is to sport in the way that the jumps or the jumps with the partner push in the air would reflect the demands of the sport.
I think
so is the perturbation training with the foot on the ground, is that bad?
bad. No, I just think that they've conversed almost something that could be a regression, because you have a reactive stationary balance thing, right? And then we've also got the higher level jumping and all the stuff, which is kind of a progression of that. And then the external perturbation, when you're in the air and somebody knocking you off and trying to land that would be a further progression. It's just they've got those kind of confluenced in together, instead of saying here's kind of a stationary reactionary drill moving into some of the more dynamic type stuff. They've added it as a component as if it's a plus to that, when it's really just the regressions that are part of their earning the right to be able to do the other more advanced progression. I didn't see that it added a whole lot of extra value.
Yeah, I'd sort of ask, and this is the, I guess, the disadvantage of getting people in late stage, but I kind of look at this, and from a clinical perspective, I'm like, shouldn't they have already been doing this? Or maybe they already did, and that's the disadvantage in this case of not necessarily knowing, well, what was their prior rehab coming into this. They could have, everybody could have already done that. That could have been, some of those things like the perturbation training, and even thinking of, well, they were doing this on people that are ACL deficient. That's sort of where it started. Now, a lot of those were the non-operative route, and they had to have, no swelling. They had to have good strength, those sort of things. And so it's like, for some of these people, like, I think, to kind of Paul's point a little bit, was that actually too easy? Like, was it not progressive enough?
I think they make it hard, but not necessarily in a way that's relevant. They do different directions with the tilt boards. They do really hard jostling of the board. They throw in juggling and standing on your head while you're doing it. But it's like, after you get to a certain point of proficiency in that, let's do something more global than this like very isolated thing.
Right. I mean, for me, the problem with the carryover to sport is we're stationary reactive. That's not a common thing in sport, right? Where you're stationary and reacting to something moving or you moving, right? You're having to be moving your body in space and then still have that capacity, right? And so it's a starting point. And then once they've shown proficiency, you do have to move on, or you're just spinning your wheels.
Meredith, when she was on 2 weeks ago, I asked her about unstable training for ACL, and she was not a fan, at least early in the process, because she was like, it's doing the exact opposite of what you wanted to do. From like, how did she phrase it? She was like, if you're already have like an inhibited quad, and then you put it like on an unstable surface, from like a neural perspective, your brain doesn't really know what to do. I probably didn't do that justice, but Meredith said she didn't like it.
Well, it like reminds me of when people are trying to do strength training on an unstable surface. Like, you can work on balance and you can work on strength, but if you're trying to build strength in an unstable position, you're limiting your strength development, right? So do you really need to do that, or can you just do them separately?
So let's jump to the results. Like, what'd they find? Make it better?
Yeah, everybody got better. Men had more thigh strength, but we also just had time going on. Do we know what that effect was? Right? And they, again, I still struggle with the fact that they call it their ACL, injury prevention program. Yeah, these are big leaps that just because we have these things, because obviously the literature tells us even with good limb symmetry and some of this other training, we still have high injury rates. So, I mean, what's the performance improvement from that standard that we have currently that this is applying? But just, other than just the fact that I don't like the name of it, everybody just kind of improved, but I don't know why. Right? I mean, we really don't know what was the driving indicator. They were moving during this period, and so they got better. Against what?
Also, I mean, this is kind of off from the results, but if you look at the table 2, there were 14 female soccer players. And this whole program, besides a little bit of the agility drills it mentioned, like there wasn't really much like acceleration or like top end speed development, like linear running. And if you have some of these sports that require those demands, is this a specific enough protocol for those type of sports?
So really overall, everything sort of got better minus quad index. And then they're really adding the perturbation training really didn't have any additive effect, right? So everything, they all got better, and really perturbation training didn't change much of it. There didn't appear to be an additive effect to the program.
And I guess my question would be, just because both groups got better, was it significant enough to change like when they return to sport?
Can we answer that?
No.
That was great confidence there, Chris.
Terry, what were your thoughts on the paper? You're giving a straight poker face. I can't tell if you.
No, it's just here to ask questions. I think the other thing, they didn't have a substantial change in in their quad index, and it's like, well, everything else improved. And so, I kind of jumped to table 3, and I'm like, well, their quad index overall is 91% to start. Like, that's a pretty decent quad index. Now, it doesn't tell me are they symmetrically strong. It just says they're symmetrical. So that may be good or bad. I don't know. Kind of their knee outcomes, for ADLs, again, that's pretty good. But these people are 5-6 months out. So none of these like patient reported outcome measures, like the global rating or the IKDC or the KOOS, none of those really jump out at me like, oh, holy cow, those are way off. Like, that's kind of what I would expect to see somebody that's 5 to 6 months out. And so minus really their quad index, I think there's probably a ceiling effect there. They can't really improve much more. Everything else has room to improve. Now, that being said, and it's like, well, can we determine did the program work? Was the program helpful? And so, no, we don't necessarily have a true control group, but we can look at, well, how many people met the benchmarks? And I think this is great that they provided this, because I think the averages, they only tell a little bit of a story. They say, how does the group look overall? But really, that gives you some information. I want to know, did people actually pass their return to sport testing? And if we look at the number of athletes in table 3 that achieve more than 90% at post-training, I don't think it looks that great. The highest one is on there, really looking at their ADLs. Awesome, but in theory, this was a return to sport program, and even on the KOOS Sport Rec, which is very sport focused, 53%, quad index 54%. So we're leaving 46% of the people are not meeting your, this 90% threshold. And in theory, that's the threshold to return to sports. So they're not even ready yet. And again, that's not entirely surprising. These people were at the start of the study 5 to 6 months out. And so at the end, then they're 6 to 7 months out. And I don't think that any of us would disagree that somebody at 7 months out probably still has some gains to be made. But what this does show me is this program isn't as much as the be all end all. And really in that regard of looking at like for even hop testing for figure 2, like at best 60% of the people in the 6 meter timed hop is pretty easy to actually be symmetrical. So it sort of surprises me that even for doing a bunch of hopping for 5 weeks, that really there were still people that didn't do well. On average, the group looks great, but you're like, you didn't even meet the needs of half of the people in the study. I think that's a problem. Again, back to the sort of the strength training component and the performance enhancement component. We're like, half of the people didn't get better or didn't achieve relevant outcomes. They may have still improved. They may have improved. They just didn't improve to the capacity where they could get back to sport.
So does that mean that the time is too short, or the number of sessions, the intervention was too short, or the intervention was wrong or incomplete?
Maybe all of the above. I would say at something's missing. Now, granted, again, these people are 6, 7 months out, so they probably in most ideal world, they would probably still have like follow-up care. Unfortunately, I hear like the people in the clinic, they're like, we don't see them after like 4.5 months. They like go away and because they're out of visits or whatever else. And I'm just like, okay, I don't like, this is tough. The other, I guess, odd world that I live in, then when I go work clinically, I just go up to the athletic training room at Creighton and we just, we see people until the end of time, till they graduate. And, so it's like, what's insurance? Like, I don't even have to mess with it. And so it's like, you just get the care that you need. And even if you don't need it, we'll give it, and so there's such a disconnect. But I would say, at least in this case, a lot of people didn't get better. Some people did. Some people met the benchmarks that they needed to. And I think that is fantastic. But I think that's where we can take this another step further and sort of begin to look at, well, why did some people get better? Who were our treatment responders? Like for some people, this program worked great. Well, you know what? I want to know more about them.
It'd be nice to have the pre-test data and look at like the line graphs of everybody, because maybe just the people who came in really good were the same people who passed, and the people who came in too deficient were the ones who didn't get any better.
Travis, exactly. Also on the like pre-test side of things, I was looking back through here and I didn't see it ever state if like the injury was on their dominant leg or not. So that kind of makes it a little. I feel like that would have been a good thing to identify.
Why?
Because, I mean, great question. I would say, like, we know that the body isn't absolutely symmetrical, but even post-injury, and like you've said, if the knee's injured, the quad shuts down, but like, to what extent, and then maybe your deficit goes, if it shuts down the quad, the losses on a dominant leg might be greater initially. I just feel like I'm not sure how they control for it really.
Well, they tested that in the other paper, or they didn't test it, but they documented it, the dominant leg for soccer. And I really don't know if that changed much. Well, for soccer, it might because of the majority of kicking, but even then they use both legs. But this reminded me of like going back to the documentation of strength training paper, that there's just and so many of these ACL papers, like so many of these protocols, there's a large majority of individuals that are still not meeting the return to sport guidelines. So this is just another example that a good amount of people are struggling post intervention.
And this is not a specific knock on the Delaware group, but this is an extremely well-funded research group. Their program and their clinic is very evidence-based, and so in theory, this is sort of the best of the best. This is like the ideal world. You know, these people are coming in, and their sessions are supplemented off of their grant funding, and so this is like ideal.
I don't know though if that's entire, like everything you said is true, right? Tons of funding, one of the most prestigious programs. But if they were really, like we said, the program required minimal equipment. So maybe they were really kind of holding themselves back from using all the bells and whistles that they have access to say, this is a program that you could do in your clinic or on your practice field, you know? And if they weren't trying to stick to that, maybe they would have thrown in some other things using some not even fancier equipment, just any equipment, any external load that might have gotten better results.
I think back to the point that, hey, this is real world. And I'm like, man, if that's as good as it gets, we might want to take a different approach here. Like if 50-60% of the people are meeting benchmarks, and probably some should be at 7 months, they should at least be getting close. And maybe those are the people that, you know, and one, I think it just shows, hey, they need more time, or they need more sessions, or I don't know what, but they need to meet these bare minimum benchmarks. But I'm like, this is kind of an ideal study, and they're not meeting the benchmarks. This isn't enough.
But is it an ideal study if it's only a 5-week protocol?
Well, but in theory, again, it's who is the intended the intended audience, and in theory, these are people that are transitioning, or at least entertaining the idea of transitioning back to sport. It doesn't mean that they're cleared at the end of this study, but like this is what it's preparing them to do. In theory, they are preparing to begin that transition back to activity, but it kind of shows me that in this group, they're not ready. And then if we break it down between males and females, the females are disproportionately negatively impacted at this point in time. So males tend to have better outcomes. Now, there can be a whole host of reasons why. We can't pick those out of this, but it just shows we probably need to take a different approach. It doesn't mean this is bad. It doesn't mean that perturbation training is bad, but this doesn't answer everything. It shows that some things do get better. The hop tests tend to get more better, if you will, than maybe some of the quad strength outcomes.
So Terry, what would you focus on then? So I think quad strength would be the one primary thing, but is there anything else?
Well, so I think that's a start. So, one concern, I guess, that I have is there is a huge focus, let's just say in this manuscript, on symmetry. but, and being symmetrical is fine, but being symmetrical doesn't answer all of the question, especially, let's just say, for an athlete. It's not all about athletics, but let's just say it is. And you can be symmetrical, but, you know, if, you know, you have a symmetrical vertical jump of 3 inches, like, that's not going to hack it at all. And, you know, you can have the quad strength of a baby giraffe, but that's like probably not going to work for the varsity high school soccer player that, you know, she wants to get back to the team. Like, that's not going to work. And so I think that's another component of it. So I think you have to have the requisite strength base and then begin to apply that. So I think the program overall makes sense. Hey, let's focus on things like jumping and landing and sort of this neuromuscular training. I'm like, great, yes, that's a component, but it's also not the be all end all. And I wouldn't expect somebody that's doing a bunch of jumping to really skyrocket in their quad strength. It's like, well, you didn't do that. Like, so it is such a disconnect in that regard. And even the perturbation training, it's like, you, other than like these hop tests, which are all really performance based. It's like, how far did you jump? And then you can stick the landing. But I think everybody on here that's seen hop testing, you can have symmetrical hop distance, but that could look drastically different. And you can still, by definition, stick the landing. All you have to do is stick the landing, hold it for a period of 2 seconds, and that counts as, you know, provided you didn't lose your balance or touch your foot down or whatever. Like, you can be all over the place, but you hopped symmetrical. Well, in theory, the perturbation training, I don't think it's bad, but I don't think the hop testing is the way to do that. Maybe we need to look at, well, what was your time to stabilization on your single leg forward hop? Maybe that's a better measure. Again, you can't measure that in the clinic specifically unless you have force plates, things like that. But maybe that's a better measure. So it doesn't mean perturbation training is bad. I also think, to kind of some of the points earlier, maybe that perturbation training needs to be more progressive in nature, and that we need to apply that perturbation when the person's in the air and they need to work on landing. A lot of people don't tear their ACL, or you don't sprain your ankle with your foot flat on the ground. You're trying to decelerate. So it's kind of that applicability, I guess, or that sport translation. But I think starting with your foot flat on the ground is a great place to start. Unfortunately, it's just not probably a great place to finish. So make that program progressive. And
you might think too that if they had measured some other, like you said, time to stabilization or some other sort of balance or stabilization component, that would have improved more in the perturbation group than the control or the group that didn't do perturbation. But obviously that, I don't know what the research says about time to stabilization and ACL injury. They measured the things that they thought would be relevant to, you know, re-injury and return to sport.
Yeah, and I think that's a little bit of the limitation associated with the outcomes.
But I'm hoping also that, especially for some of these non-clinicians right now, that when they pass, even if they pass this testing, it's return to sport programming that starts, not you're going into play. At least that's what it should be. This is just clearing to be able to start doing things that are really on the field with your sport, not necessarily full return to sport. You're earning a right to earn the right to earn the right, right? I mean, hopefully it's not just, oh, look, you did this and you're able to do that, because quality matters in these things, and being able to see how they're cutting and how they're landing and those kind of things really does, it should help drive the decision.
And so I think that's yes, they're good benchmarks. They're good metrics along the way to test and to determine, you know, have you earned that right to progress? And for the folks that haven't, then I'd say, well, then let's adjust that and keep working on that. And so for the 60 some odd % that don't even have the required quad strength, say maybe we need to focus less on jumping for just a minute. I know it's fun, but let's go build some strength and continue to build that strength. And then we can continue to progress the jumping, versus saying, do the strength on your own. As long as you're getting close, like, you know how to lift weights, go do that on your own. And then we're going to focus on jumping here.
I've got a question for Travis and Terry, since you're both the PhDs in the room. Why do you think, and this is just something that I noticed, that we tend to do a lot of research that's kind of siloed? We're going to look at the balance proprioceptive perturbation stuff. We're going to look at strength stuff. We're going to look at energy system stuff, but we don't actually blend the components that are actually going to be needed for on the field really well in the research. It's just too many controllable factors, too many variables to actually try to break out. And I mean, because we live in these little silos and then we make judgments based off of these silos, but you really don't know where to be spending your time on some of these things. We say late phase, we need to be doing this, yet they're doing static perturbation training. You know, I mean, I just wonder why there's this drift towards these silos.
I would think with this one that the purpose of the study was to determine the effect of perturbation training versus, you know, or the traditional rehab, if you want to call it that, plus perturbation compared to their traditional or speed agility plyo, whatever they did. And if you did the speed agility plyo plus perturbation plus strength plus whatever else, then you have no idea. It's like FIFA 11, right? We have no idea which components of these things work. We know that this all works, but now the next phase of this would be to figure out, all right, so what's actually the active ingredient here that is causing us to see this reduction in injury? So that's why, like, something as simple as the Nordic or the Copenhagen, that's nice because we know this is the thing, because we only did this one thing, sort of. I mean, we only added this one thing. Of course, we were doing other things. But that's inevitably the challenge with research, is that if you have too many variables, then you can't isolate what was causing the effect.
Yeah, and I think that is the clinical disconnect. And then as soon as you write that grant to fund a study, and they're like, you're studying way too much stuff, like you're never going to be able to then translate that. The other thing is whether we like it or not, really ACL injuries really aren't that common. And think about from a public health perspective, like who cares if you get back to playing soccer? There are people with cancer or arthritis or whatever else. And so there are bigger, you know, heart disease. There are bigger public health concerns than 200,000 people that tear their ACL that primarily impacts young athletes, you know, 14 to 25 years of age.
Yeah. So you really have to emphasize the burden of the injury, that, you know, because it's so infrequent, the prevalence is so low, yet it's keeping people out 6, 9, 12 plus months. So that's kind of how I guess you can justify it, along with like that statistic that Terry gave earlier, the 50% developing OA within 10 years. So, but it's still an extra step to take compared to some of these other issues that are much more tangible and, you know, low back pain. Like, let's keep studying low back pain because everybody has it, you know, and it's so debilitating, you know. And it's affecting activities of daily living, not like high level sport.
I have a question. This may be kind of like reducing it down too much, but if you could maybe make like one change to their exercise protocol to better seek the results they were looking for, what might you have done? Because I kind of have like what I think, but I don't know. I was curious if anybody else has any thoughts.
I would have continued focus strengthening. I think too often we shift away from that. They're at a certain point and we think you're at a certain level, and now the next phase is all pre-sport, all this other kind of stuff, yet you still don't have strength. Like you were saying, the indices are basically symmetry, but weak symmetry still sucks, right? So we've got to get something where we have a modicum of strength, whether it be relative to body weight, whether it be relative to position. Certain sports have positional strength metrics that they have for some of their players, right? So it should be relative to some of those kind of things before we start getting too worried about whether or not you can balance a ball on your nose and stand on a wobble board, right? I mean, there's certain things that, and Terry's kind of hit that, you need a modicum of strength no matter what. And so in this, the just air squats with the band around your knees, I don't think is enough load for somebody that far out to get any real change. And so we need to be at a level that's real change.
Paul, they
Well,
used,
and even from, yeah,
they
sorry,
used the
go ahead.
black, I was going to say they used the black TheraBand.
That is a great point. Yeah, and I think, just, and this is, back to really thinking about good strength and conditioning principles and design. And again, it has to be relevant and meet the athlete's needs as far as where they are. And maybe somebody 5 to 6 months out, this is a good start. But, I would hope that this then progresses to really look like what I would be used to seeing in the collegiate weight room setting. And that if we are looking at developing power, then the load and the number of repetitions and the volume start to match that, both from like a squats. You should probably do more than squats, but I love squats, but there are other leg exercises. And then jumps. I guess if you really want people to get good at jumps, having them do the ones that you want to measure makes sense. But also if you want people to be explosive, there are ways to do that as well. So it's a start, but it's a start.
I guess for me, the big challenge is if you know that, let's say you're discharging someone for PT and you know that they don't have access to heavy weights because they'll be training, they'll be doing the rest of the training they're doing at home. How do you best program for that in light of the fact that they are really only going to have body weight and maybe some, gallons of milk that that they can get to apply some external load?
Well, and I think, yeah, this is where I'd say, well, it sort of depends on, well, what are they going back to? And if the idea is for somebody to go back to, and hey, I need to carry the gallon of milk up and down the stairs, cool. That is meaningful. But the second that we say, well, these are actually, like, in theory, let's just pretend for a second, high school and collegiate athletes that are in cutting and pivoting sports, like, I think we do them a disservice if they don't add that back in, because I would suspect, fortunately or unfortunately, a lot of them are going to go back to their high school weight room setting or their college weight room setting or whatever it is, if these are indeed athletes. And then they're going to go from, thankfully they at least incorporated the black TheraBand, but it's like, all right, hey, last year your back squat was 265, and I know you've been out for a little bit, so let's drop that to 180, and then we're gonna start with 3 by 8 here, 6 to 8 reps. And you're like, oh, okay, well, yeah, I really didn't do that in PT. And it's like, well, I think we need to bridge that gap better. And for the clinics that don't have it, just own it. Like, it's okay. But let's get these people plugged in, because I think there is a need to bridge that. It's just hard.
Terry, do you want to move to the next paper?
Yes. I'm gonna actually refill my water for just a second, and then so take a quick break, folks, and then let's jump into this other paper that's more strength training.
Solid.
Sorry, just to speak to Travis's point that he was talking about earlier, that was kind of where I was going with that, is even if, like, they are having, like, minimal equipment, I feel like, I mean, they implemented a really awesome hamstring exercise, Nordic hamstring curl, but like the squat was so underloaded. So even if there was minimal equipment use, I feel like something unilateral could have had like pretty profound effects on it, whether it's like a pistol or a lunge or something like that.
Yeah, I think the way to go is the single leg training, and you run into, well, how do we progress that in a way that doesn't require so much balance that we can still get it loaded? So, or maybe you do eccentric step ups, but it's still like, okay, for somebody who weighs 150 pounds, yeah, like that's great and that's awesome, but you know, the forces that you experience on the field when you're cutting, like, the magnitude of those forces is more than you can probably get from doing any sort of pistol squat. And yeah, that's what I wrestle with from, you know, a PT clinic that doesn't have access to heavy weights, as well as just sending people off and knowing that they're not going to have access to weights.
Maybe some like depth jumps off like your second floor apartment would be enough force to like recreate a heavy
squat. But yeah, no, it's like depth. So seriously, though, depth jumps are a relevant thing here, but you probably need a precursor from a strength or a prerequisite strength to even get to those depth jumps. I mean, the NSCA book says you need a 1.5 times back squat, I think, to do any sort of depth jump, which is maybe bogus, maybe not. But the point is, like, you want to be developing strength before you do something like that.
I think Seth Meyers calls that a segue. So let's no pun intended, jump into this this progressive strength training. And so we've sort of, I think we've set the stage anyway for why this, you know, why strength training would be important in this case. And you know, building that in and saying, okay, well, you know, we can do better. We can have better outcomes, and, you know, whether NSCA or ACSM, and they're about the same in their guidelines, but saying, let's be more prescriptive with strength training. And so, you know, I think this next article really starts to lay that out as far as the rationale for doing this. And let's actually have a progressive strength training protocol, and then, you know, let's try to follow that. And so I think they lay out, at least in this next article, the rationale for it. It's like, well, yeah, no kidding, like, why not? And then sort of their secondary purpose, looking at differences between hamstring tendon and bone patellar bone, which we know there are probably some differences there. So it kind of lays that out. Anything else from the introduction on this this next article?
Terry, I just don't know enough about like how the metrics for hamstring ratio, how big of a role does that play compared to quad, and why does it matter?
Well, in theory, somebody should have probably, you know, their hamstrings should, you know, and it depends on what you read, but should be, you know, maybe 60-ish% of quad strength, and realizing that the hamstrings are a really good, you know, help oppose anterior tibial translation, helps just provide overall knee stability, you know, also a really good, you know, kind of secondary hip extensor, if you will. And so hamstrings matter too. It's not all the quad, but it is, but it's not. Again, I think the quad is just the most, it's the most negatively impacted. And so I think it gives you the best window into what's going on across the lower body. But I could probably tell you with certainty that if somebody has restored their quad strength, they've probably restored the strength in their other muscles. It's, in my opinion, it's a really good surrogate measure. Where that gets thrown off a little bit, though, is if somebody had a hamstring graft. So they had a hamstring injury in this case. And then their hamstring may need some time and more directed strengthening to come back. And so I like this article in regard that, hey, let's look at hamstring strength and quad strength sort of independently and together, because yeah, they both matter. Like, you know, for somebody to get back to function, that yeah, it's important. And particularly if you've had a hamstring graft, if you've had a hamstring graft, I can tell you your hamstring's going to be weak, but so's your quad. Like that doesn't, the quad doesn't not get weak. But if you have a bone patellar bone graft, your quad's going to get weak, and then it's going to get weaker. So,
Terry, oh, go ahead, Chris.
And you would assume, just based off the lack of loading of that limb in general, the hamstring, even if it was bone patellar bone, the hamstring and other musculature would get weak as well. Just
sure.
Deloading.
Yeah, I think a couple of things. Yeah, that, you know, in theory, somebody the day that they hurt their ACL, that's probably the strongest they're going to be for a while. And you know, in theory, like they were training, they were doing their sport or whatever, and then they just get nailed with this period of inactivity or reduced activity. But I think that just highlights why, again, ideal world, ivory tower, I just go up to athletics and it's like, well, let's do all the preoperative rehab and we'll see you the day of surgery or the day after surgery, and we're just going to get this thing started. And, but continuing that training, I think, is important. But yeah, all of the muscles are going to pay a penalty, even the ones on the uninvolved limb. I mean, just their overall conditioning is not going to be the same. They're not out doing 2 hours of practice every day and then going into the weight room. And so there's just this period of inactivity that they get hit pretty hard for 2 or 3 months at least. And then they got to dig out of that. So yeah, that's tough on all of the muscles.
Terry, when you said if somebody increases, you know, gets close to 100 or 90% in their quad, that you would expect the hamstring to be there as well. Is that just because when we do lower body exercises, we're training both the quad and the ham, unless all you're doing is leg extensions as part of your rehab?
Correct. And so in theory, that is really predicated on that somebody has a pretty comprehensive lower extremity strength training program. That, of course, if you're doing squats, like, you know, you can't, well, it's just all quad or it's just all glute or it's just ham. Like, no, it's everything. But I think at the same time, you do need some isolated work, particularly, definitely for the quad. Like that, no questions asked. Like you need that isolated open chain exercise. I think you're going to really, 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 really struggle to restore quadricep strength without doing those things. And then particularly for the people that have had a hamstring graft, then we need some focused hamstring exercises as well to help build that back up, because they've had a muscle injury, tendon injury, but it's a muscle injury. So they need to build that, back up. And so let's jump into the methods here with their exercise program. What'd they do?
They had a 4-phase kind of progression over a period of time that, I mean, it started off just, phase 1 was, I think, just the 2 weeks after the ACLR, the at-home full knee extension, quadriceps activation. And were you the one that highlighted and made notes on this paper, Terry?
Probably. If I accidentally sent the one that was highlighted and had all my comments on it, then I guess you know what I think.
Well, they were good comments. And I was thinking the same thing, like, and maybe it's to what you said, like, there's just not the option, but why would you wait for this phase 1 to start relatively so late? And then phase 2 was muscle endurance training, which I still think is just like a weird term. What up, Travis?
Is that typical to do such high reps at, like, in early stage rehab? I haven't seen that before, but yeah.
I don't disagree with it. And just, since we're sort of getting close on time here, I think my biggest thing with this is that, hey, we want to follow ACSM guidelines. And it's like, okay, that makes sense. And it's like, okay, then that's based on they need to be above 60% of their 1RM or whatever. Okay. Like, did you ever test it? Like, how did you know you were actually doing enough weight? And I don't see it. And I realize, I get it. It might be difficult to obtain a 1RM after surgery, maybe. But you still can kind of get an idea, or that's where things like reps to failure, I think, start to make sense that, hey, we're going to shoot for this range. I may not know your exact 1RM, but if we're just going to keep loading this up, and if we're shooting for 6 to 8 reps, we're going to keep loading this up, and I'm going to keep progressing you until you fail. Like, I hope you get to 4 reps, and then I'm going to take some of the weight. I'll back off. And again, that's provided that you're not getting knee swelling, you're not getting pain. I think we can continue to push, and you can push reasonably hard, but you just watch for all of those signs that they said they were watching for. But I just didn't see that in this particular program. And then to not do the open chain until the third phase. I get it, that there might increase laxity, or but it's like, so far a lot of the studies have shown that's not the case. And that really, if you look at a lot of just things like walking, and the tensile loads on the ACL are probably far greater. Like, things like going up and down stairs or running or jumping, those are far greater than what somebody would have even with a loaded single leg extension.
If you don't have access to a leg extension, would you like rig up something with a band in a clinic? Like, how would you try to do that?
I'd say that if you don't have that, then you should. That if without being entirely offensive, like, if you work in that clinic and you want to be seeing people with these sort of injuries, then you should have the necessary things to help get them better. And if you don't, then just don't. Like that. Again, that's kind of my thought now, because it's really hard. If you want to strengthen the quad, that it's really hard to do that without like something like a leg extension. So it gets to be difficult. And if somebody doesn't have good quad strength, like after ACL reconstruction, and you say, well, we're just going to do squats. Yeah, squats will strengthen the quad. It will strengthen the hamstring, strengthen the glute. But like, the body's going to figure out a really good way to do that squat. And we know this, like Susan Sigward's done a lot of the work with this and the biomechanics of this, and people will unload their knee. They'll use more of their hip, they'll use more of their ankle to get the job done. So it looks good, or you can't really tell, but they're just doing it different. And so are they just laying down an adaptive pattern that maybe they wouldn't need to if they were able to focus on the on the isolated strength.
Terry, was the ACL, they have referred the ACSM guidelines, is this for like the traditional like resistance training guidelines, or are these separate like rehab guidelines that I'm not aware of?
No, these are all just, and this is where there's a disconnect. And if we could just get some people to give us some money, then we could do this. But I think this is the hard part, and this is the real world aspect that, yeah, believe me, I struggle with. That it's, and I think this article, I think they're starting to get there. They showed some increased strength, and so which is good. But again, I think being able to incorporate that, and so I think you could do a 1RM. There's nothing wrong with it. It just might not be great. And it's like, okay, well, what if it hurts? Well, then they probably shouldn't be doing that yet. Like, then we need to work on something else. And so I think that, but I think, the body doesn't care if it was hurt or not. And I think, and so kind of the question being, should the guidelines be different? And I'm like, no, the muscle doesn't care, like, that the body was hurt. And so we need to progress them to be able to tolerate those loads. And so, that's where I like this article, because I think it shows conceptually that hey, this can be done. Like, they didn't get hurt, but I also think at the same time, I'm like, I think they can take this a step further. And particularly, the hard part of this is that, they use male soccer players. In theory, we're all kind of amateur or professional level. Their control group is actually more amateur than their intervention group. And it's like, well, when their intervention group's a little bit stronger, it's like, well, no kidding, they were like better athletes. And it's like, you compared them to the fourth tier amateur league. But I think it does show that, people can get better. But again, just like the other article, where 66% of the people had a quad LSI above 90%, it says you didn't meet the needs of 44%. And so it shows that it works for some people, but there are still gains that can be made. And they're following these folks out to 9 months. And so they're making some progress. But again, I think their strengthening program could be more as well. I think they could have just done they could have done more on the strengthening side of things. That they show their exercises, single leg, one leg, but I'd say, well, how much load were you using? And back to the original article, I think being able to track that, and this is where I think like volume is important. How many reps did you do? How much did you lift? And for how many sets? And let's track volume. And did the people that maybe did more volume, they got better? And so that's where I think the volume aspect is important. So I think this particular article helps move the needle, but again, I think we can continue to progress this. And that's where I think, working with the strength and conditioning professionals, or having that background, or both, where I've transitioned a lot of the rehab that I'm doing. Yeah, there's still a time to be in the clinic, but usually for folks that I'm working with, after 3 months, we're probably doing almost all of our rehab in the weight room, and we're grabbing dumbbells and things like that, because the 10-pound cuff weight in the athletic training room just isn't enough to get the real gains that we want to see. And so I like this article. I think it makes, or it helps progress things. But I think, again, it maybe just wasn't enough. And that's all right. Another unique aspect, they actually looked at their strength normalized to body mass, and there's some reasonable data that you need to be above 3 Newton meters per kilogram of body mass for quad strength, and probably hamstring strength you need to be about 60% of that. And so this starts to look at, were they strong and were they symmetrical? And the answer is on this is some of them were, but some of the control group wasn't even there. So it's like, well, damn it! Like now it's like, what's normal? Like I thought 90% was normal, it's like the control group wasn't even normal. It's like, oh, I don't even know what to think. But I think, I'm pretty convinced though that being symmetrical and being strong is important. But I think that's only a component, that these are very, essentially these are very sterile measures done in the lab, and that we have to be able to transition that to the field of play. And that's where I think, the folks that have a good strength and conditioning background or sports science background, or the strength and conditioning coaches, we can help transition that and build that. And so then from a research perspective, those are the people, from both a research and a clinical perspective, those are the people that I want on the theoretical team working together. But I think that's the other advantage of working in collegiate athletics, is we have that. If we can transition, working with the athletic trainers or the physical therapists or the strength and conditioning coaches, and if somebody's struggling on the psychological side, we can get them plugged in with sports psych. And so it's very comprehensive, and it's still not ideal. We still have our student athletes at Creighton that don't meet these benchmarks. And so even from my perspective, I know that my rehab can continue to get better and develop. And at the end of the day, it's very patient focused, so there's a lot of things that play into this, and yeah, it's frustrating.
From your perspective at Creighton, those individuals that you're rehabbing that still aren't meeting where you want them to be, or just a general question, what's the biggest thing that you're trying to work on now within like this protocol?
Well, so, we focus a lot on strength, and we focus on strength early on and developing it, and it takes time. And what I'm seeing is this is a very time and labor intensive process. And ideally that and sometimes I don't start working with somebody and, they've been out of surgery for 3-4 weeks. And I'm like, man, like if I go back in time and I'd love to have started working with them before surgery or right after surgery and things like that. Like that would be really helpful. But I think that's the hard part. So yeah, we focus on that big time. So, and then it's just, getting them, just getting the good volume, and that's hard, but that's where working with the strength coaches, I think is helpful.
With these papers, you had a little earlier talked about volume and do you think it's important to actually post that in these studies?
Sorry, my audio cut out.
Can't hear you.
Pretty sure I broke it.
Can you hear me now?
Yeah, I'm good now. Sorry.
Okay. Do you, in ideal world, do you think these papers should post the volume landmarks or the volume kind of progressions for these athletes, or kind of some averages to see what's actually changing?
Well, yeah, I mean, that's a whole nother, that's really labor intensive to then start tracking volume. Like that's just, but strength coaches do an awesome job of this. And so I think that is possible. But it's probably harder from the PT clinic perspective. But I think bringing some of those things in and saying, hey, let's really look at, is there a better way, and what can they tolerate? And so that's where, at least at Creighton, that I we can track things like volume and really push that envelope. But even then, what it's taught me is it is still a slow process. It just takes time. That they have pretty substantial muscle weakness, and that's they just gotta dig out of that, so to speak. But
part of this, I think part of this, and excuse me, but
yeah,
it's such an individual basis, right? I mean, so what's too much volume for you may not be enough volume for me, right? And so again, we have a watering down of what this metric is, unless we can partition out these individuals, and what are the markers that we're going to do to partition out for these individuals, right? I mean, because we all know those guys that walk past a weight stack and they throw on muscle, right? I mean, they're out there, right? I hate those. Yeah. But and then there's other people that just can't gain no matter what they do. Well, those programs are going to be different, right? I mean, they're going to have to be, or they're going to respond differently to that individual program. It's just one of those things that I always look at. Okay, the research is a starting point for me, but I've got to figure out for this individual, what are these tolerances? What are these loads? What is this volume need? How are they responding? And so, it's a starting point. It's not the answer for the individual in front of you. You still have to use critical thinking and testing and seeing how that patient is going. That's the key.
Oh, definitely. And that's, that summary is absolutely spot on. That, hopefully these things give a good framework to start. And I think they give a really good framework, and your rehab should be probably pretty close, to that framework, and realizing it's going to vary some, but, kind of back to the point of, maybe for the folks that aren't incorporating weights whatsoever, or that aren't incorporating single leg, knee extension, or aren't incorporating NMES, early on in the rehab process. I'm like, we're probably missing some of these absolutely critical components. And it's like, yeah, but they're functional. We're doing jumping. Okay. So it should serve as a good guide, but yeah, that's it. It's never like it. Unfortunately, it's not cookie cutter, which, I think that's the beauty of what we do. And there's definitely a science component, and I think it needs to be driven by that. There's also that art component, and having that understanding and being able to put those pieces systematically together to help meet the patient's individual needs is important.
That was great. I think that's a good spot to wrap up.
Yeah.
Unless anyone has any final questions?
I did have one final question. Just because I'm not really at a place right now where I'm seeing. I know this is kind of like our last week of ACL, but I'm not really at a point in my career where I'm seeing 3, 4, 5 ACLs in a day. Like I think would be really cool, but maybe more like 1 a week or 2 a week sometimes. And so a lot of the information that I've kind of gathered over these past few weeks, I'm also applying to some of my other post-op knee patients or knee patients in general. Do you guys think that that's, wrong? Or, is a knee and muscle, kind of trying to progress them in the same way, but maybe just rather than, them kind of going along this part of the timeline, maybe my post-op TKAs or something like that, just doing this early phase kind of stuff and almost using the information in the same way. just because there's so much research on ACL, I feel like it's a good bank for us to pull a lot of that stuff from.
I think it's a good model. I think from a research perspective or a model perspective, I'd much rather work post-op meniscectomy. It's a very clean and fairly standardized surgery, but whatever. But I think with any of this that, yeah, I think that's the beauty of it, is that it's a model. You know, in my case, we're using the ACL as a model to investigate changes in neuromuscular function after injury. It's a model. But the things that we learn, yeah, you bet, can be applied, maybe the same, maybe a little different, or modified for somebody with patellofemoral pain or knee OA. But at the same time, realizing that a knee injury, and again, those neuromuscular consequences, probably carry over to somebody that has a shoulder injury. It's different, but it's a joint, and so it responds and it swells and it's painful and muscles are inhibited and muscles get tight and become facilitated or whatever. And so it's a model. But I think, again, with that model, and where I like on the research end of things, is the research is very systematic. But I think that's how good clinicians operate as well, that you have those built-in feedback mechanisms to say, here are the benchmarks that I'm looking at to determine, is the person getting better, worse, or are they staying the same? And then what's my progression? And so I think that the systematic nature of the things that we talked about apply really across the board. It just may have to be adapted for that person, but that systematic process does not go away. So yeah, keep learning, keep committing to that process, keep refining that process, keep reading. You know, I think that's the other way that you build your volume is, you know, if you're only seeing one person per week, that's really tough to become really an expert in that. But the more that you read about that, then you can identify and pull that in and help build that experience. Thank you, everybody.
Thank you, Terry. This was great. Freaking crushed it. I wish there was like a clone of you that we could bring to our university. Well,
oh, it's fun.
Move to Creighton and chill with Nate.
Terry, how's your grant going? Did you get it all done?
I got it submitted on Wednesday. It was due on Thursday, and so they give you a little bit of time afterwards to like review and check everything. And so I'll probably do a little bit of that tomorrow and just hit the final submit button. But yeah, so slight backstory, a lot of the grant that we submitted. So I worked on a Department of Defense grant that we submitted and have been submitting. And it really focuses on a very systematic, progressive strength training approach. And sort of our control group is based on like the Moon guidelines. And we've really tried to build the rationale for these other programs aren't bad. We can just do better. So here's our opportunity to do better. We'll see if they do it. But yeah, it's the main program is 20 pages. The whole thing's probably close to 400. It was just disgusting. But we're getting close. I'm committed to it. I think it's the right thing to do. So.
Is this the best one yet?
Definitely. Absolutely. I say that every time, and you know, we get knocked down and we you know, we may not get it, but I would swear up and down that is the best work that I have done to date. We'll see.
Sweet. All right, Terry, thank you so much.
Thanks, everybody.
Joining the party. Y'all enjoy the rest of your Saturday, and I'll talk to you later.
Very good.
Thanks, Terry.
Bye, guys.